Good morning, everyone, and welcome to the MDFT Multi-Dimensional Family Therapy Informational Webinar, which is being hosted this morning. I want to thank everybody for joining us today. I know everybody's really busy and you're taking some time out of your morning to learn about MDFT and how it can better serve Connecticut, and so welcome. My name is Dan Rezende. I am the President and CEO with the Connecticut Junior Republic, or CJR. And I will be today's MC and leading today's program. So bear with me. This is my first time doing a virtual conference, and well, I think we'll get through it. We have some great tech support on the other side. So again, good morning and welcome. MDFT addresses a wide range of youth behavioral problems, including substance abuse, delinquency, antisocial behavior, aggressive behaviors, school and family problems, emotional difficulties. And what's great about MDFT is that it can be implemented in a variety of different treatment settings, such as substance abuse and mental health services, child welfare, and juvenile justice systems. This can include outpatient, in-home services, and residential programming as well. Drug courts, detention centers. It's a very flexible model which fits into a variety of different settings. It has a strong research component and great outcomes. It has very high satisfaction rates from the young people in the program, the teens, the adolescents, and the families, the parents and the therapists, as well as the community collaborators. All think this program is really, really effective with this target population. We're here this morning because we believe that Connecticut's youth and families need more of these types of programs, needs more programs like MDFT and MDFT specific services. And it is my pleasure to advocate on behalf of this program and this service and to be with you here today. A few details about our program of today's webinar. The program is going to be an hour and a half long, and this is being recorded. All of the attendees out there are participating in a listen-only mode, but we have enabled you to interact with us through the chat box at the bottom of your screen, where you can ask questions, and we have MDFT experts on the other side that will answer your questions live in the chat box. So please feel free to ask questions and to communicate with us, and we will get you information based on where you have some questions and where you want to get more information. We'll also be able to get back to you with these questions and answers at the end of the session, which again, we will record and get directly back to you about specific questions, especially if we need to do a little research on some of those answers. We will get back to you. Again, we want to make sure that we're able to communicate with all of you and answer all of your questions. And now I would like to kick off our program and do that by introducing Dr. Gail Dakoff, who is the director of MDFT International. MDFT International, of which Gail oversees, is a 501c3 charitable organization that facilitates and disseminates the implementation of two evidence-based programs: multiple dimensional family therapy, MDFT, and also multi-dimensional family recovery, MDFR. Dr. Dakoff is a scientist, clinical practitioner, and specializes in the development and testing of psychotherapeutic and systemic interventions directed towards treating substance abuse, mental health, child maltreatment, delinquency, criminality, and a host of behavioral issues and family-based dynamic challenges. Instrumental in the research and clinical development of MDFT, she is a master trainer of MDFT and the architect of the MDFT training and implementation approach. Dr. Dakoff is the principal investigator or co-investigator on numerous NIH-funded research projects and has authored over 60 publications on MDFT services. She is also a voluntary research associate professor of public health sciences at the University of Miami Miller School of Medicine. Gail received her doctorate in psychology at the University of California at Berkeley, and is a licensed clinical psychologist in the state of Florida and California. On a personal note, I've known Dr. Dakoff for over 15 years and find her to be one of the few evidence-based model developers that implements a model that is flexible in its approach in development, implementation, and also working with funding sources, specific programs and communities to make sure that the model fits the needs of that specific environment. Gail is very passionate about her work and ensures that the children and families of which MDFT is in charge of serving are healthier and better off the day they leave than when they came to us. And so it is with that, I will kick off the program. And Gail, here you go.
Thank you very much. It's been a pleasure and an honor to work with you all these years. It's been a great collaborative experience with you, Dan, and really everybody in Connecticut. So let's start. You know, this has been a really difficult year for all of us. It has been, and it still is. And families need help more than ever. The need for behavioral health care is great and growing, as you can see by these headlines here. And I'm sure you all read about this every day in the newspapers, listen on the television and radio. But I think it's important to realize that even before the pandemic, only a small number of people who needed behavioral health care services received them. And a tiny fraction of that small number got high quality evidence-based services like MDFT and MDFR. The COVID pandemic, however, has exacerbated an already existing behavioral health care crisis. So I feel a sense of great urgency and need to do something and to do more right away. Multidimensional family therapy and multidimensional family recovery are both whole family approaches that have been rigorously studied and are among the best behavioral health programs in the world, really. These are programs that you would want for yourselves and your families, that I want for myself and my families if we were ever having difficulties. MDFT helps youth ages 9 to 26 get and stay on a safe and healthy developmental trajectory. And like Dan said, it effectively reduces substance use, violence and aggression, criminality, mental health symptoms, improves school, vocational and family functioning. And this has been proven in numerous randomized clinical trials. And it's not only that it effectively reduces, but it reduces it to a greater extent than other treatments, including some other evidence-based treatments. Multidimensional family recovery is based on MDFT, but it's a different kind of intervention. It's a specialized child welfare intervention that helps parents involved in the system meet the expectations that child welfare DCF has for them and prevents child maltreatment. I'm going to take my next few minutes and talk more about MDFT, and then later in the program, we'll talk a little more about MDFR. So first of all, MDFT works. As I said, as Dan said, it's proven in over 25 years of research and over 20 years of implementation in the United States and Europe. And it also saves money. We all know that spending on mental health and substance use disorders is very high, and MDFT can lower the costs by reducing hospitalizations, residential treatment, incarcerations, and repeated treatment episodes. So it's really the best of both worlds. It's highly effective evidence-based treatment, and it won't break the bank. Let's go to the next slide. I'm just going to go fast through some of the highlights of MDFT. So it works and it saves money. Fantastic. It also works with diverse populations. Research has said that MDFT stands out as the most effective substance abuse treatment for youth of color, particularly African American young men. It's a one-stop shop. It's both a mental health and substance use treatment. It provides in an integrated fashion individual therapy for the youth, parent education and support, family therapy for youth and parents together, and services to address basic needs and other barriers to success. And it works fast, takes about 5 or 6 months, and the effects last over time. And again, we've got research to demonstrate that it lasts for many years. As Dan mentioned, MDFT has been in Connecticut for a while, and we estimate that it's been delivered to over 10,000 families, to a diverse population, primary low and moderate income families, and youth with, if we can see the next slide, and youth with multiple challenges and comorbidities. As you can see here, mental health disorders, violent behavior, violence in the home, substance use. They're really suffering. Next slide. Yet in Connecticut, as elsewhere in the US and the world, the results are really excellent. That's why we're here today. First of all, we know that 93% last year, this is data from last year, 93% of youth and families who started MDFT completed it. And that's really excellent in that in general, fewer than 50%. In other treatments, fewer than 50% complete treatment. Sometimes it's as low as 30%. So the first step is you've got to engage them in treatment, and MDFT is excellent at that. Then the outcomes are also excellent. And this slide here just give you some examples. If you want more information about MDFT research in the US and the world, and Connecticut in particular, reach out to me. But you can see here it reduces hard drug use, which we define as pretty much anything other than marijuana and alcohol. In Connecticut, these are opioids, benzodiazepines, meth. And so that's a tremendous reduction because it's hard to change the behavior. It reduces family violence by a significant effect. And the third one there, it improves academic performance. Last year, academic performance, grades, attendance, participation improved 37% from intake to discharge. And I always find that remarkable because it's a short-term treatment, and to improve grades in that short period of time is really something special and important, right? We know kids need to go and do well in school. At discharge, the youth are doing well. 92% are living in the home, and less than last year in Connecticut, fewer than 8% had to be discharged to a higher level of care, defined as a juvenile justice facility or inpatient treatment, residential treatment, rehab. And that is excellent. Again, because we get kids that are suffering from many problems. 85% at discharge have stable mental health functioning, and 86% have no new arrests. So the results are really fantastic. Next slide, please. Do we have a slide? Oh, sorry. Okay. So what you can see is the youth, they come in and they're suffering. There's a lot of challenges. They're not doing well in life. At the end of this 5 or 6 month treatments, as you can see by those outcomes, they're really functioning well. And so we can really say that they are now on a safe and healthy developmental trajectory, life path, that they can move forward in life and do well. And that's what it's all about. I'm gonna read, I wrote out last night 5 key reasons why I think that MDFT should be available to all youth. And I wanna quickly go through those if I may. First of all, it works, as we've said. That's number 1. It reduces symptoms, it improves functioning. And it works better than other treatments, including other evidence-based treatments. And it's so powerful an intervention that it prevents incarceration, residential treatment, hospitalizations, rehab, and thus it saves families and states much needed funds. It's effective with diverse populations, as I mentioned, including youth of color. And there was a review of 5 studies that included MDFT. And this study found that MDFT was the only treatment that was effective for African-American young men. Other treatments were somewhat effective for other groups. MDFT always more effective, I might add. But for African-American young men, the other treatments were not helpful at all. Only MDFT was helpful. So that's really important to us. And its effects last. Any decent treatment will improve functioning while the youth is in treatment with the therapist. But only MDFT and studies indicate, let me be more clear about this, that only MDFT effects last for many years. So we've done studies where with comparing MDFT to other excellent treatments. And as I say, as the youth are in treatment, the youth and families are in treatment, they're all doing better, and that's great. But once they leave, the youth in the other treatment, they start to use drugs and have more mental health symptoms, and there's more distress in the family. But with MDFT, they maintain those treatment gains over time, over many years where they've been studied. So it's because of these reasons that I am so passionate about the fact that I want every teenager and young adult who needs MDFT to get it. Now I'm going to, I know that's kind of a fast run through. Now I'm going to introduce Sandra Arguelles. Sandra works at Connecticut Junior Republic, and she started as an MDFT therapist and then a supervisor. And now for the last few years, she's been an MDFT trainer, training therapists and supervisors in the MDFT approach right there in Connecticut. And she's going to give you some talk about her experience with MDFT. Sandra, it's all yours.
Thank you, Gail. So good morning, everyone, and welcome. As Gail said, my name is Sandra Arguelles, and I've been a national trainer now with MDFT International for a couple of years, and I've been doing MDFT for about 8.5 years now. I work at Connecticut Junior Republic here in Connecticut, and time flies when you're having fun every time I say how long I've been doing this, because it truly speaks to how much passion I have for what I do. I started my journey as an MDFT therapist and then moved into a role as a supervisor and a trainer. And so I want to begin today by showing you a video that showcases one of my favorite things we do in MDFT. The video you're going to see is in Spanish. So when Gail was talking about, diverse population, this truly shows that MDFT works, with many types of families. And there are subtitles, but this is a real MDFT family that one of the therapists I trained worked with. Let me first give you a little background before I play it. The mom was physically and emotionally abused by her husband, father of their adolescent who we were working with. And he was the adolescent, a witness to this abuse. In order for mom to sort of begin to escape from this abuse, she decided she was going to, begin to work more hours. And so she was out of the home more often at some point. And during that time, the adolescent then became the victim. He was the one who then began getting physically abused by dad without mom knowing what was going on for many years. And so while working with the MDFT therapist, the adolescent opened up about his abuse for the first time. And she knew, the therapist, that this was important for him to share with his mom, that mom needed to know what his experience was and what was going on for him, what was on his mind, why was all this pain so, what was happening that was causing so many pains and the behaviors she was experiencing with him. And so the therapist prepares him to open up to his mom in a family session. This session was about 2.5 hours. And this is what the outcome of that experience was.
Me voy a rendir por él, y como dice que si no lo quiero, yo no lo quiero, yo lo amo, porque él ha pasado mucho y él es todo para mí. Y siempre estoy orgullosa de ti, muy orgullosa de ti. Por ejemplo, este viaje que vamos a hacer a México, yo le dije yo no me quiero ir sin ti porque no me voy a ir completa. Yo quiero estar contigo porque aunque sea de lejos, pero no me voy a rendir, mejor. Voy a luchar hasta donde podamos. Y vas a contar conmigo siempre.
And so a short clip, but as you can see, it was a very emotional experience for this family. And I've been doing this for a long time. And one of the many things that fuels my passion for training therapists is being present to witness families experience moments like the one we just saw. No matter how many times I watch this clip, it still pulls at my heart. And this tug or, that pull is so important to the work we do in MDFT. And personally, it's my favorite. You see, because in MDFT, therapists are taught to be intentional and to think deeply about their cases. They begin their sessions knowing that what they have planned is important to the enhancement of the family's well-being. As trainers and supervisors are teaching therapists are going into homes and teaching families. They teach them how to be present with one another, how to listen when it's hard, how to validate and be open to hearing really difficult things. Therapists help them connect to why it's important to keep fighting and not to give up. It's through that experience that hearts heal, that their minds become calmer and their relationships are rebuilt and families are emotionally reconnected, just like you saw in this video. Just yesterday, I was working with a therapist preparing her for a live session. And she's a therapist who's now in the process of becoming certified as an MDFT therapist. And the session didn't go as planned. It actually went even better than she had envisioned. And the session was with a mom and a daughter who have learned to stay away from each other when things get heated for fear of an argument getting out of control, right? So basically, in mom's words, I pick my battles with her, she says. And so in this session that I was helping and preparing the therapist, we talked about helping mom explore with her daughter how shutting down helps her. What's the purpose it serves for her? And what kinds of things is she feeling when she feels she needs to go there? The adolescent was able to open up with her mom and tell her when she shuts down, it's because she's thinking about her grandmother's recent death. And they've had a lot of death in this family. So this was even much more impactful. But she felt like she didn't want to share these things with mom because she knew that, mom goes to work. And if she's worried about me, she's not going to do a good job while she's at work. And she wants her to do well. And so I asked the therapist after our session how the experience was for her. And the therapist says she was surprised how much the adolescent said. And when I asked her, well, what do you think happened? How do you think that happened? She realized it was the first time mom was able to say, tell me what's going on. I want to understand so that I can be there for you, right? So this was the first time that mom was sitting to her, looking at her daughter and saying, help me understand. I want to know what's going on, giving her permission to really be open with her mom. And so instead of what she would normally do, which was to avoid her, I then asked the therapist, well, how did mom do? How did mom know what to say? And she replied, because I taught her. And she was absolutely correct. And this is the beauty of what we do as trainers and supervisors. And just an MDFT, it's such a full team support. Therapists are never alone in what they're doing. And the therapist did just that. That's exactly how the family you saw in the video I showed you just a few seconds ago was able to experience each other in a way you saw, because the therapist knew what needed to happen and taught them. And we as trainers, along with the supervisor, help therapists do this beautiful, emotional, difficult, but very necessary work. And you're probably saying, well, doesn't every therapist help? How is MDFT therapist different from others? The difference is our focus, our deep understanding that families each have value and that the core to bringing them closer is to teach them in real time, right in the session. And so we don't just talk about how to communicate, we have them do it. And we don't just talk about how to express love and care, we have them do it. And we don't just talk about trusting each other, we have them do it right in these sessions. And so I'm sure many of you are familiar with the screenwriter, Nicholas Sparks. He's actually one of my favorites. And, all of his movies make my heart warm and fuzzy. And for me, this feeling never gets old. And neither does being a part of the journey with the families we serve in MDFT and what they get to experience. I really hope that you can see the passion that, you know, I not only have for what I do, but I think it's something that is, you know, always so useful, and knowing that therapists also have this and they go into families with that same motivation. And so I really appreciate you taking the time to be here with us today and for hearing a little bit about MDFT and later about MDFR. And thank you for having me and listening to my stories about MDFT and what I see and how it helps families connect. It helps families rebuild, and it certainly helps families love again.
Sandra, thank you very much. That was really a moving presentation. And I want to also give the therapist and the family some credit for sharing with us and allowing us to see that. It was very moving, and it showed the dedication of the commitment of the clinicians to supporting those families and those children to ensure they get to a better place. So thank you very much for that. At this point, I want to introduce our panel for a panel presentation. First, I'd like to introduce Michelle Melendez. Michelle is the Director of Substance Abuse at United Community Family Services. Jennifer Nadeau, who is the Service Director at Community Health Resources. Kim Nelson, Chief Program Officer at Wheeler Clinic. And Kathy Scheisel, who is the Senior VP of Child and Family Services at Community Health Resources. Welcome, everyone. We're going to have a little bit of a informal kind of discussion about MDFT services within each of our organizations. And I'll throw out some questions and let's just have a working conversation that we can inform our audience about MDFT services. So I'll just start right out with, how did you see MDFT working and fitting in with your organization and the culture of your programs and what you're trying to accomplish? How does that fit into your agencies, your specific programs?
I can start, Dan, if that's okay, because I was just looking at some of my notes. But as Dan said, and thank you for having me, my name is Kim Nelson, and I'm the Chief Program Officer at Wheeler. And I'm proud to say, and I don't think I realized it, but Wheeler is approaching our 18th year operating MDFT services across the state of Connecticut. And I believe we've only been capturing, we've been capturing data for maybe a little over 8 years, and we have served close to over 1,350 youth in the program. So what I can say is that it's embedded, MDFT is embedded into our culture as an organization, into our commitment to really produce positive growth and change in individuals and families that we see. And that we have experienced just significant success with our families and our youth that we have served within this program. And we have been a part of MDFT International training. We have, I can't say enough about MDFT. It's my favorite model of all of the evidence-based practices that we work with at Wheeler, and we work with a lot of them. But MDFT is flexible, it's caring, it's supportive, it's with the family and the youth, and it's where the family and the youth are at any given time. And so I can't say enough. So I just wanted to start there. And I'll leave by just saying MDFT is really the go-to. It is the go-to model. Thanks.
I can piggyback on Kim, Dan, and just say think about UCFS and how it fits into our culture, and thinking about the MDFT being the go-to model. I think about how it fits in with UCFS around MDFT. We have the therapist assistants, the therapist, and I think working as a team and helping the community where the community needs really resonates within MDFT and UCFS as well. And I think about, as Kim was saying, we really work with the families where the families are at. And so I think about sometimes we have clients come into the clinic and do a clinic session, or we have we're in their home, or I think about the therapist assistance that I feel is really key to some of working with our families, is having that therapist assistant who is a bachelor's level person who in some cases within the MDFT cert, we also have recovery coaches. So it's people who've had lived experiences helping these adolescents become sober and stay out of harm's way. And I think sometimes I think about a recovery coach who has shared with them or has been in that place with the client around how do they get better. And I think that resonates within the community about how MDFT can really help the clients where they're at.
Yeah, I agree with that, Michelle. Anybody else have some thoughts on that?
I just think the other piece that is so important with MDFT is that focus on the entire family system and the heavy focus on engagement. So, you know, the flexibility of dealing with whoever is there for the session at that time. So if, you know, mom is there, but youth has something else and they have chosen not to be present for the session, we can intervene with the parent. If the youth needs to have the focus that day, we intervene with the youth. The model is so flexible in that regard and really focuses on the entire family system and their issues.
Yeah, I agree with that too. You know, just within, you know, the CJR system of services, you know, we run a continuum from, you know, prevention to clinical service to residential and school programs. What's great about this model is that it fits into each of those areas, right? So if we get a kid that comes to our door or a family that gives us a phone call because there may be some substance abuse with the young person who may be our identified client, and then we come to find out there's some mental health issues or there's some school issues going on, or maybe there's some community risk factors that they're involved with, that this model addresses all of those domains at one time. We don't have to send out the young man and the family to go to a substance abuse clinician for that program and a mental health clinician for this program. This model wraps everything around that youth and family with one identified clinician and one identified support system. And, you know, supports basic needs, housing, education. If they need food, the tech assistants help with all that, helps them get in a better place so that the therapy is more, you know, stable for them. So what I like about it is that it's very all-inclusive, it's flexible, and it works with kids, you know, again, as Gail says, from 9 to 26. So, you know, young adults, transitional age youth, adolescents, developmentally aged kids, because you're working with the whole family unit. So it can meet kids and families at any venue, any point of that continuum. So I think that's really effective for us.
One additional comment that I will also add is with MDFT, we're able to meet all clients, all youth, and it's not restrictive to really a referral source, or you don't have to, you could come in any door and you don't require a specific insurance or payer or referral source. So one thing that we have enjoyed is we never have to turn a youth away, a family away with MDFT for inability to pay or because they're coming in a wrong door. So with MDFT, there really isn't a wrong door.
So Jennifer, how about you? What do you think with things going on with the model?
Yeah, so
how you see it?
For sure. So I think, you know, one of the misconceptions that a lot of people have about evidence-based models is that they're very cookie cutter, right? And that they're not flexible. So I think one of the things that everyone has highlighted so far is really that flexibility piece, right? That we're really meeting the youth and the family where they're at. And so it really is an individualized approach based on what the family needs at that point in time. And I think that's one of the things that really makes MDFT as successful as it is with the families that we provide services to.
So what do you feel that are some of the, MDFT components that help with some of these outcomes that, Gail mentioned, the reduction of substance abuse, the increase in academic performance, the youth are able to stay home and there's no need for, higher levels of care and placement. So what do you feel about, why that happens through this system?
Yeah, I mean, I can kind of chime in there. I think, part of it is because we're so flexible, right? We are able to remove a lot of barriers for families that they may have to participate in other forms of treatment, right? We're removing barriers related to transportation because we're going out and meeting the family and the youth where they're at, right? In their community, in their homes. We're able to go out to schools and other clinical settings, right? To really engage the youth and the family from the very onset of treatment. I think we're also super flexible in that oftentimes we're actually meeting with the families even before we're completing our intake assessment, right? To really start that engagement process before we've even started treatment. So I think all of that really just helps the families to see that we're really willing to work with them and be flexible. And I think that engagement is so important to the rest of the work that we're able to do with families and why our outcomes are so successful.
Anybody else want to add on to that?
Yeah, I would also add that I think our flexibility, but I also feel, and with our flexibility, that we have the opportunity to not only work with the family as a whole unit, but we can work with the youth alone, we can work with the parents alone, and then bring the family. And so I think sometimes with our engagement around that, sometimes we may need to bring in the parents first and help them engage, and then have the youth engage first. And I think our flexibility around that also helps us be successful because we can have a relationship with both the parents, the child, the adolescent alone. And so I think that helps with our success as well.
I think
Yeah,
another important component also is that, you're preparing the family members for a family session, right? And so oftentimes with some of our other models, our staff just aren't as comfortable doing the family intervention. MDFT really provides the training and the practice to help folks feel more comfortable with that family intervention. And we know from research that really that family intervention is such a huge key, right? Here at CHR, we really strive that 70% or more of our interventions are always family interventions, because we know that that's how families, get the help they need in order to address the issues that they have. So I think that is a huge key. And, that looks different for every family. So preparing a youth to have a conversation with a parent, or preparing a parent to bring up a difficult issue with a youth, or something that the youth has witnessed or seen or felt over, from multi-generations in their family, is so important.
Yeah,
Sorry.
Yeah, no, that's a great point. One of the things that I think is really effective from my viewpoint is that it works really, really well, this model, with the older age adolescents and the transitional age kids that, a lot of our other systems seem to struggle with, kids that are, 16, 17 to 22, 23 years old. And, we started a program which was residential based, short-term residential treatment, where we did MDFT and then followed them 6 months post with MDFT services in the house. And a lot of people told me that they didn't think that the model would work with the older kids. They said that the parents were burnt out on them, that they had tried a lot of other services that weren't as successful, and that, the kids were almost independent. And what we came at it, and what MDFT comes at it, is that, no matter where the parent is, if the child lives with the parent, if they live with another relative, if they're in another system, the parent still loves their child and still cares deeply about that young man or that young lady. And they're going to work with that kid regardless of where they live, because they're a family. And if you come at it from that perspective, it always seems to work, right? No matter what traumas they've gone through in the past, no matter what crises they've had to deal with, if you come at it from the basic point that mothers and fathers and caregivers will always love their children, we can work off that, and we can build off that, and we can always engage upon that and be successful. And so it worked really, really well with the older kids and the young transitional age young adults, because even though they may not be living at home, you know, they still were, their parents were still their parents, and they still had issues they had to deal with and work out. And so I thought it was really great to, you know, to highlight that and to show people that that actually was a misnomer, that, you know, just because you're older doesn't mean you can't do family therapy. That's a real misnomer, and a lot of models don't look at it that way. But MDFT looks at it, it's a family inclusive model, no matter where you are, no matter what age you're at. So, you know, how about, you know, what does MDFT do, you know, if we're struggling, to get, you know, people to show up for appointments, for example? So, you know, if we are maybe we got a referral on a young man, and he's, you know, not at the point where, you know, he's showing up for appointments. What do we do for that? You know, some models just cancel those cases, right? Because they're not showing up, they're not getting paid. What does MDFT do?
Well, I can tell you, I often hear about certain situations, and I feel sometimes like we're stalking them. We go, we go, we go, we go. We don't give up. Oftentimes, we're looking at the clinicians, and we're seeing, wow, they did 10 sessions this week with X family, and the leader will say, oh no, so and so was not home, not found, and we just kept going until we engaged. And if we don't find the youth or the family home, well, if the youth's not there, we work with the family. I mean, that's, or the caregivers or whoever is a part of the system. That's one approach. But the other one is we'll go to the school, we'll go to the community, we bring the families together. So there is no barrier there. If the family, if it's a working family, we provide, you know, appointments or flexible scheduling in the evening. If the youth is resistant, we engage that youth, whether it be by food or another activity or engagement strategy. So I think that's the thing about MDFT that, again, is really special, is we don't give up.
Yeah, and I think it's really important to note, because, you know, many other services, especially within our, you know, medically based behavioral health system, is that if they don't show up for appointment one, we give them another appointment. If they don't show up for that appointment, they get canceled out and they don't get any of the services. To me, if they're not showing up for appointments, it means they are at higher risk and have more needs that we really have to then do outreach to go get them. And this model allows for that.
Yeah, MDFT is really a model that we do whatever it takes to get the youth and the family engaged in services. And I think one of the things that's unique about MDFT, I think Michelle was speaking about the therapist assistant and the recovery support workers that we have that are working as a part of each team, right? So there's support that's there for the family. And I think one of the things that we've learned over, you know, our years of experience providing MDFT, that oftentimes providing some of those case management supports, right, and getting you know, kind of like some quick wins for the family in terms of supporting them, whether it be with their basic needs or whether it be connecting the youth to pro-social supports or activities, that oftentimes doing that very quickly in the beginning of services helps us with that engagement process.
And that works so well with the young adults. So, you know, that 18 to 21-year-old age group, those case management needs, or really going out and finding those young adults as to where they are in the community, is a key to that intervention. We've been working, you know, doing the ATM model through the ASSERT grant with young adults, and have found, you know, that it makes a huge difference when you go out to them in the community, kind of see where they are and who they're with. And then, you know, really give them hope around the case management pieces that you can put into place, that's a real draw for them. They tend to be a population that is harder to engage. And so those pieces really, really work very, very well.
Any last thoughts before we wrap up here and move our program along? All right. Well, listen, I want to thank everybody for your time and for your input here. I think your perspective definitely shows the flexibility of this model, the degree to which organizations and agencies like ourselves, which have a long history of being successful with this population, engage and promote this model because we know it works. and you know, how flexible it is with different populations, whether it's in the juvenile justice system, behavioral health, you know, school-based issues, or traditional family-based issues and trauma areas. So thank you very much for all of your help and input, and I look forward to seeing you soon. Bye. All right. So now we're going to go to a part of our program. We're going to do some family testimonials about how MDFT services have helped their families. One is a video recording of a family that was worked with by a CJR MDFT clinician. And one of the families is a family that is with Wheeler Clinic. And I believe the therapist from Wheeler Clinic, Ashley, will also have the mom of that family in treatment live with us at the end of this presentation. So that'll be fantastic. So with that, we'll jump right to our video and our live presentation.
Hello, thanks Dan for the introduction.
Well,
I'm Ashley Dolheny. I'm a program manager with Wheeler Clinic, and I was the therapist for this family. So my client's mom, Jessica, is here with us today. Jessica, it's a pleasure to be here with you today. To give everybody a bit of a reference about your family. So your son, Danny, and your family with Wheeler Clinic's MDFT program in 2018 because of a pretty significant transition that was occurring in the family. Can you talk a little bit about what was occurring at that time that brought your family to MDFT?
Sure. So my son had chosen to move to Virginia with his dad in 2016 when his dad was relocated for his job. And it didn't really go that well there for them as a family. So my ex-husband dropped on my porch kind of against his will. Like, he didn't really want to come back because he had made friendships in Virginia. He was doing well socially there, in his opinion. So he was pretty upset about coming back here.
And with that came some defiance and some family conflict between you and him.
Correct. I mean, he was like really, really angry.
Yeah. So let's talk a little bit about what your experience was like with MDFT, what changes you saw, and how things evolved. So how did MDFT make you feel? What did you take from it? What was impactful for you?
Well, what was impactful was help with communication with him. Like, I think sometimes the way I was speaking to him was not in a way that he could receive information in a way that was helpful to him. So like, I felt like having somebody else there to sort of not referee, but like regulate the conversation and direct the conversation was really helpful. I also appreciated the persistence in that Ashley was with us like at least three times a week, working with us as a family, working with me as a parent, working with my son individually. So like, he was speaking to her probably in a more candid manner than he would speak to me. And then she was getting us to talk to each other about the issues that he was having. So, and also another thing about that is I felt like I could reach out to Ashley at any time and she was available. So I felt like I had someone like in the middle of this crisis where I could text Ashley and be like, here's what's happening right now. And I need help and he needs help. And can you check in with him? And she was always available.
Nice to hear you say that, Jessica. Thank you. And I also asked the same question to Hanny. So let's hear from Hanny in his own words on his feelings about MDFT and what was impactful for him. Just
like the constant support and like someone kind of looking out for me was very impactful.
yeah. So it seems, were you able to hear that?
Yes.
Yeah, okay. So it's nice to hear him say that, and it seems like the two of you, felt that both felt that the support was impactful and something that you really remember from the program.
Yeah.
I also asked him about what changes he was able to see from working with the program that showed that things were moving forward in a positive direction. So we're also going to listen to that clip.
I mean, I stopped getting in fights with my mom for the most part, which was good.
So he said that he stopped getting in fights with you. Do you agree with that statement, or how do you see it from your own perspective?
I mean, I would say from like the beginning when we started out to the end, he was a totally different kid. So it started out like he was angry, defiant, difficult. And from my perspective, I think I underestimated the trauma that he experienced. So like you were helping me understand like what that would have felt like to him so that I could communicate to him in a way that was sort of a little more sensitive to that and understanding. So like the reasons that we were having a lot of fights was that maybe I was expecting too much or misunderstanding. So I think it was definitely, we did have less fights. It was for reasons that are more complicated than it sounded like he was giving,
Yeah. But it sounds like the both of you, are on the same page with what you got out of MDFT, and it seems that it was really helpful and impactful for your family.
It
was able
was.
to shed some,
Absolutely.
Well, thank you so much, Jessica, and thanks to Hanny for his participation also. So we will now hear from a family who participated in Connecticut Junior Republic's MDFT program.
Guys, throughout that time?
It was nice. Jason and Andre, both were good. They really helped me, and they really helped me for me and my son to, learn to get along. And even if we didn't get along, when one get mad, give the other their space. Mm-hmm. And they taught us a lot. Yeah. We have come a long way.
Oh, that's so great to hear. Helping him with his anger, communication. What other things do you feel like you learned throughout the time with MDFT?
Oh, learn to cope with my anger too and my emotions, and stop trying to be so underneath them rather. Mm. I learned to give him a little more space, give him his freedom. Mm-hmm. Because I'm gonna be honest, I'm hard on him out here. I just want him to succeed. That's all.
Yeah. And when it comes from a place of love, right?
Yeah, but I don't want him to go down the wrong path. Mm-hmm. I want the right way, not the wrong way.
But it says so much that you were able to recognize, like, hey, I can make some changes too that will help my son.
Yeah.
That's huge.
Always told me to, if I ever have a problem, I could call him anytime I wanted to, even if it's on the weekend. And I really appreciated that.
Yeah.
You know, sometimes on the weekend I did call him.
Mm-hmm.
I was like, I'm sorry, I hope I ain't interrupting your weekend or whatever, but I really need to talk to you and tell you something. You know, if something's wrong with my, you know, they was very helpful. Jason was very helpful.
Good.
He less angry. I give him that much, Megan.
Mm-hmm.
He ain't as volatile as he was before in the beginning. He's doing good. He's learning to control his anger.
Good. So
yeah, that's what I'm saying. That's what's making me want to go to school. But from learning from Jason and Andre,
mm-hmm.
that I don't always have to be in one spot all the time, and I need to do something anyway, because life is, I don't know, life is just too short.
Yeah.
And I need to do something. I'm 51 years old, and I just need to do something.
Yeah. Well, so, and you know, Kamanti was our client, but really the whole family is our client. So I'm glad that you were able to find some things for you too, that you were able to notice and recognize and work on.
Yeah, I've been looking into it. I need to do something.
Good for you.
For Mom, and I don't have nobody here for me, so
good.
I got to do what I got to do.
Yeah, good for you. You can do it.
I'm going to try.
You're very strong. You've been through a lot.
I have, Megan. I'm going to try, though.
You can do it. I bet you Kamanti will be your biggest cheerleader. Will you be a good support for your mom, Kamanti?
Yeah.
Yeah, I bet you will.
So I want to just thank everybody for their participation. I want to thank Jessica and Ashley for doing a live presentation. Thank you so much. Your comments were both very moving and very touching, and I think it goes to show exactly where the therapy and the clinicians want to move families to that point of being able to communicate and get along and to move forward. And I think that, and also our video presentation with Megan, Jennifer, and Kamat, they also showed that, this model is family focused. It helps, the caregivers, the parents, as well as the identified client, who's often the young person who's sent to us for a variety of reasons. But it's a model that is focused on helping the whole and is holistic in its approach. And I think you were able to see that. So I want to thank everybody for that. That was fantastic and very moving, and it takes, it takes a lot to be able to come forward and talk about that. So I want to just thank everybody for that. And with that, I want to move forward and give this back to Gail. Gail's going to talk about MDFR and also have a panel presentation on some of those services for funding and resource allocation. So Gail.
Oops. Hello. It's me again. We're going to take a little pause from MDFT, talk about multidimensional family recovery, and then go back to MDFT. But we want to spend a few minutes to introduce you to MDFR. Multidimensional family recovery is based on MDFT. So some of what you heard about MDFT, the flexibility, the family focus, they're very similar. Let's do the next slide. Let me tell you what it is. MDFT, as I mentioned before, it's basically a child welfare intervention to help families who are involved in the child welfare system and also themselves, the parents, have substance use and mental health challenges. So it helps parents enroll, remain, and benefit from substance use and mental health treatment. It improves parenting practices and child safety. It reduces multi-generational conflict. Again, that whole family approach will work with the parent and his or her kids, grandparents, aunts, uncles, and it improves family communication, very similar to what you heard about MDFT doing. Ultimately, in MDFR, we want to change parents' lives so they can maintain their sobriety, are adequate parents for their children, and avoid further involvement in the child welfare system, because nobody wants to be involved in the child welfare system. It does this by promoting change in these 6 domains. So it's very comprehensive, as you can see here. Let's do the next slide. And it works, right? There have been research to show that it works. A review of 20 different intervention programs focusing on child maltreatment, as an example, found that only that MDFR, and 2 other programs were the only programs that prevented or reduced child maltreatment. So 3 of 20, and we're one of those 3. And so that's really excellent. It works because we've got to know it works, and we've got to have research to back that up. Next statement. I'm going to go through kind of fast. These are from research studies, give you a little sense of how it works, what it does. First of all, it effectively engages parents in substance use treatment. As we mentioned, that was an important goal. And you can see in this study, 88% of parents who got MDFR, in comparison to 46% of parents who got another intervention, enrolled in treatment. 88% is a very large number, and there's a big difference. So it's effective in engaging parents in treatment. And it increases the likelihood of family reunification among families where the children have been removed from the home. We found in one study, 70% of MDFR families were reunified in comparison to 40% of the other group. Then there's another study that looked at how it increases the likelihood of positive child welfare outcomes. And you can see here again, MDFR is very effective. And finally, I want to highlight, its effects on the termination of parental rights, which is the most extreme negative outcome when you're involved in the child welfare system. And we found that families who got MDFR, 23% had their parental rights terminated. These were families that were at very, very high risk of having this happen. And 48% of folks who got intensive case management services, they had their parental rights terminated. So again, huge difference to show that MDFR is very effective and more effective than standard alternative treatments. It's been compared to home builders type model, case management, intensive case management, and we always see the same results. It's also shown to affect other outcomes better than intensive case management. One study we found a decrease in substance abuse, a greater improvement in mental health, greater improvement in family functioning, and a greater reduction in the risk of future child abuse. So that's super important because that's what we're trying to do. So brief run through of what it is. The research supports its efficacy. And now I'd like to introduce to you Stacy Oliver, who works here in South Florida, is from South Florida. She started as an MDFT counselor, supervisor, and now she's an MDFR trainer in the state of Connecticut. She's been doing that for a few years. And Carol Ann Donahue, who is an MDFR specialist counselor working in Connecticut at CHR. And they're going to talk a little bit about their experience with MDFR.
Thank you, Dr. Daykoff. Good morning, everyone. As Dr. Daykoff mentioned, MDFR helps parents enroll in, remain in, and benefit from substance use and mental health treatment. I came to MDFR from a program that provided short-term in-home services aimed at stabilizing families with DCF involvement. So that idea wasn't new to me, but what was new and different was MDFR's approach. MDFR is not substance abuse treatment, but the sessions and interventions used are therapeutic and looks just like a therapy session. MDFR is also not case management, although some case management duties are performed in order to assist parents and remove any barriers that they may have that may hinder them from participating in the program. MDFR workers are change agents who intervene and provide parents with the tools needed to accomplish their goals while also promoting the behavioral change needed for long-term success. With MDFR, it isn't simply about telling parents what they need to do to get DCF out of their lives. For the most part, our parents know what they need to do. Their struggle is following through and actually doing the work. So this is where MDFR takes things a step further, not solely focusing on the parent and their needs, but focusing on the entire family, the parent, the child, and the extended family, providing that parent with total support, helping parents see that hope is not gone, they are still in control, helping them to decide what they truly want and what may be motivating them to get what they want, and helping parents see why working the program could be beneficial to them and get them what they want, which is usually to get DCF out of their lives or to get their kids back home with them. And all of this is done in a non-punitive and non-authoritative way. Although sometimes the workers will have to challenge a parent's behavior or discuss discrepancies, but this is all part of the process. For me, I found it really made a difference when I approached my parents from a place of support, respect, and understanding, listening to what they had to say, being non-judgmental, and validating their feelings. When I first went into a parent's home for the first time, it wasn't about completing paperwork. I knew that the paperwork would get done. So I didn't focus on that. When I went into the home, I asked the questions, why am I here? What brought DCF into your life? And I allowed that parent to tell their story. I believe that this made the parents see that I was there for them and cared about what they had to say and how they were feeling. And that made a difference. It made it easier for them to open up a little bit more, or at least let their guards down and everything, and speak with me. The fact that MDFR is a change intervention and not treatment allows for the worker to fully concentrate on the parent as a whole, their overall need and well-being, helping a parent identify their strengths and supports and building on those strengths and supports. As we all know, family plays an important role in our lives and in our successes. And unfortunately, many of the parents that we work with DCF involvement, they don't have that family support, or at least they're not utilizing their supports, which makes it harder for them to reach out for help when needed, or even see possibilities of success that they can have. So with that, so in MDFR, we work to bridge that gap, mend familial relationships, reduce any negativity that may be spoken to or about the parent, improve communication between the parent and family members, and increase that emotional and practical support that parent may need to get what it is that they truly want and to succeed. And this is all done in the effort to help our parents maintain their sobriety, be the best parents that they can be for their kids, and avoid further DCF involvement. It's easy for me to speak the positives and highlight MDFR because it's a program that I truly believe in, and by working the program, I've witnessed change in the families that I've worked with. But I think it'd be better for you guys, so you guys can get a better understanding of the program in Connecticut by hearing from firsthand account from Carol Ann and everything, which like Dr. Dakoff said, she's an MDFR specialist at CHR, and she's here to tell us a little bit about her experiencing implementing the program in Connecticut. Carol Ann?
Thank you, Stacey. So as both Dr. Dakoff and Stacey have introduced me, my name is Carol Ann Donahue. I'm an MDFR specialist for Region 3 in Connecticut. I've been doing this work for 2 years, actually 2 years this month. So I've been able to see firsthand how this program works. So I'm going to share a story with you about a family that I worked with recently. To start, I'm going to give you some basic information, and I'm not going to share any, specific identifying information. But this family was a makeup of a mom, a dad, and a newborn baby. The parents were really young, early in their 20s. The family entered the system when the baby was born substance exposed. So, and additionally, both parents had been children in the system because of their parents' substance use and mental health. So on paper, this case didn't really have an encouraging outlook. So an MDFR referral was made to support the family. After MDFR admission, both these parents discontinued their substance use entirely, entered treatment, and achieved a lot of goals. My role included providing them access to treatment, some basic case management, psychoeducation on parenting, which included safe sleep, and both parents were new drivers. So we reviewed car seat safety. We were able to have a lot of meaningful conversations about building healthy relationships. But the part that's really exceptional about this program is this family piece. So of all the programs that I've worked with, this program has a unique approach to the family relationships. These parents identified a maternal great-grandmother as their only support, but there were some difficulties in their relationship. So I met with the great-grandmother one-on-one to kind of explore her perception of the relationship. And she was able to talk to me about her thoughts and feelings about the parents, which included just simple things that she didn't like about their lifestyle. But she was clear that she loved them despite her opinion. So my role, I was able to listen, respect her opinion, validate how she felt, but then teach her how to support the parent without being condescending or demeaning, even if it was unintentional. So later, I was able to kind of witness how my conversation and my teaching of the great-grandmother transpired to the parent. The parent shared with me that the great-grandmother told them that she was proud of them. She told them that they were good parents. And it was really a wonderful shift in that family relationship, which is the goal of my conversation. So in the end, the family was successfully discharged from MDFR. The other component that's really distinctive about this program is the training and supervision. So I receive, regular emails, resources, training materials, but I also get access to weekly or biweekly meetings with Daisy for one-on-one guidance with my cases. And this is instrumental to my ability to apply this model in the home. And that's just something that I'm not, familiar with because it's so unique to this program. But it's helped me tremendously with just helping these families, and it's been amazing.
Thanks, Caroline.
I think it's so, I'm so happy that it's working well. And I think the story, Carolyn, of your family, it always that touches me. And it's just one of hundreds, of course. We have lots of stories that, these two parents are young. They themselves were in foster care in the system, and we know all the disadvantages, conflict in the family. And I remember when we were talking about this case, you said the great-grandma, she disagreed with a lot about the parents, how they lived their life, that they weren't married and this and that, and that you really, and this is the MDFR approach, I believe, you went in there, and MDFT actually, you met alone with the grandma, you listened to her concerns, you didn't belittle her, you didn't argue with her, you understood, but then you helped her realize that to get in touch with her, the love that she has for her great-granddaughter, the hope that the granddaughter has, and how much the great-granddaughter needs the grandma to support and believe in her. And so I thought it was just great that you respected her and you enhanced the sense of, helped her get in touch with her feeling of love and wanting to help, and helped her figure out a way to talk to them, the kids, without, as you say, demeaning them, to be more effective in how she communicates her desires and supports them. And of course that, and then you talked about how the granddaughter told you, oh, great-grandma, she's believing in me, she's proud of me. And we know, we see this, all of us, MDFT and MDFR, we see how that has such a strong impact on the client, right? That fact that someone in your family who you had a difficult relationship with, who didn't believe in you, is now believing you and giving you positive affirmations. I just think it's a beautiful example of the family aspect of MDFR.
I agree. And also validating that parents, what they were feeling. Sometimes we have our parents and, they've lost hope and they feel like everyone's down on them and they shouldn't feel a certain way. And I think it's very important that when working with them, we validate those feelings that they're feeling, letting them know it's okay, and what you're feeling is real, and we hear you and we're here for you and we'll help you move forward. So just the communication and showing validation and understanding is very important.
I agree. I agree.
Carolyn, do you want, or Stacy, do you want to say anything else about MDFR? I know it's kind of quick, but before we move on, to give folks a sense.
No, I'm good.
I think I covered everything.
Okay, great. Was wonderful. Thank you. And you can learn more about, if people want to learn more about MDFR or MDFT, you can go to our website at mdft.org. You can reach out to me. More than happy. Okay, moving right along. I think it's me again. I know we're kind of going from one thing to the other. I want to talk just a minute before we move on in our program about our vision for the future, our aim, our dreams for MDFT and MDFR in the state of Connecticut. Next slide, please. What we want to do three big things. We want to sustain and support our current programs. You've heard from some of them. There are many provider agencies listed here in Connecticut offer MDFT services and MDFR. Some provide both. And we'd love to expand that because as we said at the beginning, the need is great. There are many teenagers, young people who are in need of treatment and aren't getting any treatment and not getting the best treatment available to them. And we would just like to see that happen, of course. So we want to increase the number of programs. But also I want to take a minute to talk about MDFT for young adults. In Connecticut, there are currently, from a SAMHSA grant to DCF, there are 4 programs that treat youth up through age 21. So it extends a little bit. And these are youth who are at very high risk for opioid use disorder or actually have opioid use disorder. And that's been very interesting. But MDFT, we've adapted it to go all the way through age 25. And I want to talk about this a little bit because I'd love to see MDFT for young adults in Connecticut, given how great the programs have implemented MDFT for teenagers. So let's just take a minute to talk about this. Over the years in the field of psychology and social work, we've recognized that the young adult period is its own unique period, a developmental period that needs special attention. And one thing that has brought everybody to that is research that shows that young adults have higher problems, a host of problems, than teenagers and then adults that are not young adults, right? So 26, 27, 30-year-olds and so on and so forth. To just show you a little bit, they have more substance use, more depression, higher rates of serious mental illness, higher rates of criminal behavior, higher rates of drunk driving. It's a lot. So they've got a lot of problems, a lot of risks to deal with in this difficult transitional period from being a teenager to being an adult, and lower rates of referral to treatment, lower rates of completion of treatment, and lower rates of success changing their behaviors. So it's really a high risk group. And so that's why we said, let's see if we can bring MDFT to these young adults through age 25. And we thought that it would be relatively easy to do because, as everybody has been saying, it's a very flexible intervention. It's a family intervention. We meet with the youth, the parents alone, youth alone, parents alone, family together. But as everybody has been talking about, it's flexible. It needs the youth and family where they are at. So it seemed like it would be relatively easy to adapt it. And it was. We recently completed a study, and I just want to share a little bit of those results. Should be published soon. First of all, people often say you can't do family therapy like MDFT with young adults because young adults won't want their parents involved. They want them out of their business, or the parents, as Dan, I think, mentioned, they're burned out, they've had it, they don't want to be involved. We found that was not the case. In this study, over 90% of the young people who we approached agreed to involve their parents in MDFT. And 100% of the parents said, yes, I'll come to therapy, and they participated fully. So we know that young adults and their parents will participate in MDFT. And the results, the outcomes will show you maybe they should, right? So we found 95% of those young adults and their parents completed the course of treatment, which again is really excellent, a high rate. And next slide, I want to just share some of the outcomes. We found a 93% reduction in days used any drugs, days that the young adult used any drugs, 98% reduction in days of alcohol intoxication. And all these young people had drug abuse problems and were involved in the criminal justice system. And 86% of them had no new arrests from intake into MDFT through 18 months after intake. And remember, MDFT is only 5 or 6 months. So they had no arrests in the period immediately after. So this tells us that MDFT for young adults, it's feasible, it's doable, they'll participate, the parents will participate. We have an adaptation to it that we're doing a little bit in Connecticut up to 21, but you could go even longer. And the outcomes are really impressive. And again, that's what it's all about, having good outcomes, helping young people and their families. And now I wanna just have you hear a voice from the field. This is a judge who saw many of the young people in her courtroom, and she saw the changes that occurred when they received MDFT. So let's hear from the judge.
To goodness, we have seen a turnaround in these families that is near miraculous. We, for the first time, are getting 100% compliance from the young adults. The parents are coming into court and saying to us, we can't believe it. Like, I've seen a complete turnaround. I've changed, my child's changed. We love the therapist. We are so grateful for the therapist that's coming into our home, working with our family. A whole new avenue of communication has opened up. What is so surprising is it's worked with families that were so fractured that I felt it would take years to get the parents and the child or the young adult speaking to one another, even in a civil manner.
Gail, thank you so much for that presentation. And I also want to thank Carol Ann and Stacy for their presentation on MDFR. You know, having, you know, any type of an early intervention, clinical intervention in the beginning of anybody's tenure with the Department of Children and Families and the child welfare system ultimately leads to a long-term prevention outcome for the kids and those families to get them out of the system. You know, people often ask me, you know, how do we deal with kids in the highest end of the system that are in long-term residential care and in the juvenile justice system? And I always tell them the best thing we could do is get really productive and effective early intervention programs. So I think that MDFR is something that we should really look at and expand upon for that level. And of course, I do follow your thought processes on the older adolescents and young adults. Again, I've seen this model work really, really effectively with that population. We had kids out of Manson Youth Institute coming to our program, and they were really, really effective. So with that, to keep our program moving along, I want to introduce Peter Panzarella. I've known Peter probably for about, I don't know, 20 years at this point, maybe longer. Peter is a current MDFT board member and is also the past director for the Department of Children and Families, Office of Intimate Partner Violence and Substance Abuse. And Peter's one of the people that brought MDFT to Connecticut a long time ago and has always been a true supporter of this model of intervention. And so with that, Peter, I'll let you introduce your panel and go forward. Welcome.
Thank you. Thank you, Dan. Nice to see you again. As Dan said, I'm retired from DCF and I'm a volunteer on the board of MDFT. And we have a great panel today. Some of these people have been around this program a long time. A little bit of a history briefly is we started MDFT with a SAMHSA grant in Hartford. It was a competitive grant and the village was one of our major partners. It was the first time we got funding to do this program and we started with the village, and two of the people, and Catherine and Hector from the village are here with us, and Jean and Bethany are from the Yale Child Study, who I've worked with for many years. And they all have experience, especially Catherine, and about the implementation. And it was in the beginning, we had to figure out how do you transport something that the research supported, and then how do you transport so it works here. We did this project in Hartford and had UConn do a evaluation and found really good results. But in the beginning experience, maybe we can start with the village and then we can talk to the people from Yale Child Study and their experience. Catherine and Hector, you might want to kick us off.
Sure, thanks, Peter. Thank you so much for this opportunity. I think MDFT is certainly near and dear to my heart. I've been involved with it for the past 18 years from when it did come to the village. And I have to say that the work that we've done in Hartford with MDFT has been with a population that has really been a tough population, really a population that has struggled. I remember our very first case was one where the young woman was trafficked. We were able to work with her and her mom to get her out of that situation. We've also worked with gang members to help to get them out of gangs. We've worked with youth who were involved in drug trafficking. So I say that to say that the population that we've worked with has struggled a lot, and we've still been able to consistently have great outcomes with them, outcomes that have been able to be sustained over time. We still see some of these families that we worked with many years later come back to us and talk about they now have children and talk about how MDFT has changed their lives. I think another piece that's really important about this is that, and I know a lot of people talked about this, the training in MDFT really makes for excellent therapists. And other people in the agency tend to look to those that are trained in MDFT to support other programs in terms of learning family therapy, learning about adolescent development, learning about working with substance using youth. So all of those are really key features of why MDFT has been really successful in our agency.
Thanks.
Yeah, and it's, Peter alluded to a SAMHSA grant bringing MDFT to Hartford at its origins, and currently that's how we provide the service at the village. We embedded it as a key component of our Certified Community Behavioral Health Clinic application to SAMHSA. And we were lucky enough to be selected to be a CCBHC. And we think a big part of it is the choosing of such a strong model like MDFT in a targeted population of substance abuse, which we know is really the second pandemic that is occurring with opioid use and other substances. But SAMHSA is funding MDFT again in Hartford, and we have Peter and others to thank for laying out the groundwork so that we can continue this work.
Thanks. Jean, you've been a pioneer in-home clinical services and probably a national figure in that field. I was wondering what your experience of working with MDFT and then Bethany on the clinical side of implementation.
Well, Peter, first of all, let me say thank you to everyone who's brought this together, and that we've been able to come together with you. That we've spent some wonderful years under your leadership, Peter, and we're delighted. I'm also really happy to be part of this with Gail, because the sad story of Yale and MDFT is that we had a number of years of being excited about providing MDF services and recognizing the value of it. And Bethany, you can talk a little bit about the families that have benefited from it. But our data was wonderful. We got the results that Gail is talking about. And then the contract was ended for us. So we're in a position where we want very much to return to the MDFT family and be able to provide the kind of family service that we think is absolutely incredible. We believe that it is essential to be working with kids, particularly kids who have substance abuse problems or problems of transition, problems of aging out in some ways of the department, to be able to work with them in a family setting and to provide the kind of support and understanding that is essential, not only for the generation we're dealing with, but those generations that are yet to come. So Bethany, I know you have a few things that you want to say about the cases that we treated, multiple cases over the 6 to 7 years that we had MDFT and had its precursor in the state of Connecticut. We are no strangers to doing work in the home and recognizing the value of that work.
Sure. I think similar to what Catherine was saying in terms of Hartford, we're based in New Haven, and being able to provide the services to those families in need in New Haven, they were very difficult cases. Multiple levels of issues across generations. Many of the youth have had multiple failures of other treatment interventions. And I think we were able to come together as an MDFT team. We had a very large team that really benefited from the MDFT approach and training, and we're able to really engage these difficult families and promote some really significant outcomes. I think as we've heard throughout this presentation, the outcomes were strong. Decreases in arrests and substance use, mental health symptoms, and increasing family functioning and school attendance. These were consistent outcomes that we saw across the years. And I think it promotes an area that we're currently not serving, as Jean mentioned, at the Child Study Center, that we really would like to get back to.
And as you say, we are not serving the needs of youth with substance abuse problems. That's clearly a need in the New Haven area on the part of the kids, but it's also a need in the Child Study Center to be able to be responsive to the problems in the community. So we really look forward with a great deal of pleasure to being able to get back into the MDFT fold and be more responsive to the community.
Okay, thanks.
One thing I'd like to jump in and say in terms of what we see in Hartford. So because the village is so closely embedded with different services in the community, we work closely with CCMC, we work closely with youth services in City Hall. We know that right now there's a crisis in the emergency departments, right? Where we have young people that are sitting there waiting for services that are not, where an outpatient level of service is not really the appropriate level, where they really do need an in-home level of service.
That's right.
We also see, because we sit on the youth violence prevention program panel with the city of Hartford, we see the number of youth that are involved in stabbing incidents, in gunshots, youth that are really involved in criminal activity that need some support, especially that young adult age that Gail was talking about. And there's a real dearth of services for them. So again, I would just say from where we sit, we can really see there's a gap in services for an in-home level of services working with the population.
Catherine, it's interesting that you raised that, because that in itself is a very large problem in the state of Connecticut. Kids who need an in-home service need more service in order to stop sort of revolving through the EDs. They're stuck in many ways.
Exactly.
And the system really it is in the midst of a crisis about that. And I think how we can put our heads together and think about the ways in which we can be creative and innovative, and who needs to participate in the paying. I mean, I think bottom line for all of that is, where are the payers? Who are the payers? And how are we going to create a better system for kids so they are not stuck between a rock and a hard place, a hospital, and no ability to go home. I'm glad you brought that up for us all. Yeah.
Thanks.
So I just want to thank the panel for your presentation and your input. Again, I think what we've seen here today is that the need for this level of service and the ability to meet the current needs, especially in our current environment where we're facing, the fallout from this pandemic, both behaviorally, socially, and economically. This model can help us in a variety of ways with a variety of different populations. So I want to thank you all for your input on that as we go forward here. At this point, I want to show a video, a testimonial from one of our clients that was a CGR client. His name is Ryan. Ryan was in the MDFT program a few years back and was in a program that helped him with opioid addiction and substance abuse. And at this point, I would like to show this video because I think it shows that the long-term impact that this model can have as he's now a young adult. So we can show that video.
What was kind of going on for you? What led you to MDFT?
It was a lot, everything in my life was kind of going wrong at the point in time. I was in and out of programs, seeing the judge every other day. At first the program was mandated, but after a while it kind of grew on me. I was just doing a lot of bad things, stealing, robbing, drugs, anything you can name. Eventually, I stopped stealing and robbing, but was left with one of my hardest tasks, which was drug abuse. My drug of choice was Xanax. I used to believe that it would help me forget and alleviate my stress, but it made it build up and eventually explode.
Wow.
I blamed all my issues on family members and things that happened in my life, when in the end, it was kind of my fault, and I had to stand up for myself.
Wow.
Before entering the program, I had a good 10 or more felonies.
Wow.
I had time in juvie, residential center in the middle of absolutely nowhere. I don't even know what the town was called.
Oh my gosh.
None of the, it didn't really teach me anything though. I kind of kept doing the things I was doing. And after a while, my sister took me in because I wasn't doing good at my grandma's house, and under her supervision, I kind of got more respect and grew up a little bit more. But, I was still sneaking around doing this, doing that, But after a while, I got sent away for Christmas, and I realized, I don't like being away from family. I don't like missing holidays. This isn't fun. I'm sitting here, no phone, nobody I know. Just, it was just horrible.
Wow.
But eventually I learned there was more, more important things in life and not to dwell in the past. But for years, I was dependent on drugs and basically a zombie. I mean, I have no recollection of 2 years of my life because of, I think I have some kind of memory loss because of all the things I was doing. But, learn from our mistakes and better ourselves down the road.
Yeah. Thank you for sharing that. So MDFT was kind of after a lot of all those things. You had kind of done lots of programs prior to.
Yes, I did.
Yeah. Wow. So what was it like for you working with MDFT after having been in all those different programs?
It was different because, instead of just the common questions yes, we had the questions are you suicidal, blah, 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 and all that, the questions I had to ask. But, it was more of a personal experience. I got to know my counselors, Jasmine, Matt, Elise, and, they all gave me respect and showed me that they actually cared. So, it took a while for me to open up and to everyone. But after a while, I realized that, yeah, this is their job, but they do care and they want to see their clients get better. So, as I became more comfortable with the staff, enabled me to open up more and discuss more of my problems.
An individual and family, but also obviously you mentioned school and like peers and that kind of thing. So did you feel that it was kind of able to help you in a lot of areas?
Yeah, I feel like I was kind of a mean person. I mean, I kind of calmed down now. It just, first thing I started to notice was with family. For a while, everyone saw me kind of as a loser drug addict, who had no motivation or ethic to do anything in life. But, after a while, everyone started to be proud of me. I was getting good grades, I was going to school, I was going to work every day, working out, and I was finally feeling good about myself for once. And I didn't need drugs to block out my emotions. For once, I was content with life and stuff. My family could tell. They could tell I was getting better. I started, looking at colleges and getting my financial aid ready and everything. So
that's huge.
I started being responsible.
Yeah. And that you've been able to sustain it. I feel like that sometimes could be the hardest part.
I mean,
I think the program just helped him get the structure that he needed. He had no structure, it was just, I'm going to go to school, not do anything, hang out with whoever I want, sneak out whenever I want. And, coming to live with me and starting the program and making him accountable for everything throughout the day, throughout the week, and having to report back on it and, kind of reflect on the good and the bad. I think it just, made him so much stronger and helped him get to be as mature as he is now.
What has been your greatest success?
Beating Xanax.
Yeah.
100%. That was probably the hardest thing I've ever done.
That's amazing.
Well,
yeah, really
took
is.
time, but I got there.
But you got there.
Absolutely.
Absolutely. Yeah.
Yeah. Anything else you guys wanted to mention about MDFT, or anything else that maybe I didn't touch on that stood out to you?
I think with the program, it also helped us, have a little bit more of like open communication, because, we were going into it like, newbies. I was like playing the parent, and Ryan was just living with his sister for the first time. And like, I kind of had to do the parenting role compared to like a friend sister role. So it kind of helped us have like the communication that we probably wouldn't have had. We probably just would have been bickering back and forth, and I would have been like, this is what I say and you're going to do it. And he would have just, been like, no, I'm not. And I think having the structure of the program, letting us talk, and also seeing it from another person's side that had nothing to do with us, their reaction to the situation and, just guiding us through it. I think that was the most impactful.
Yeah, what an adjustment for you guys. Like you mentioned, just him moving in with you, and it sounds like it was good for you guys to have the extra support.
Yeah, 15-year-olds, man.
Yeah.
There's something.
I can't imagine.
Yeah, but I mean, that wasn't easy either. I was like 20, 21, 22.
Wow.
Yeah.
What incredible thing you did.
Yeah. That's my bro.
Anything else stand out to you, Ryan?
Well, yeah, I'll say one last thing. The program, it showed me how to be close with my family, how to deal with my issues. It showed me that people would be there for you, especially the counselors, Matt, Jasmine, Elise. They all helped me miraculously through this rough patch in my life. And, I'm glad I met every single one of them and appreciate their help. The last thing I want to say is no one will change unless they really want to change. It's coming from yourself, but having a counselor really does help. It gives you the push you need to get the next step in your life. And, I just want to thank you again for everyone who helped me. And I wouldn't be where I am now without everybody.
Wow. Well, thank you guys so much. And the time today, and even this was 2 years ago for you guys to come back, and it just means a lot to the program, but also it's inspiring. We don't always get to hear the successes. So it's nice to see you, and I wish it was in person, but to hear your story and look at how, you should be really proud.
We are. Absolutely. And we appreciate you guys.
Thank you.
So I just want to thank everybody coming today and participating in our presentation. As you can see, this is a model that I believe the people in our audience, the advocates, the state officers and department heads, the legislators that joined us today, really should look at in terms of expansion, because this is a model that's strength-based, holistic, it's data-driven, it's cost-effective, it saves us money in the long run, and it's successful, as you could hear by some of the stories. I, as a taxpayer, I would urge money to go into this system. And as a provider, this is the types of programs we want to run because we know they get results. So please look at it from that perspective. If you have any questions, please feel free to follow up with us. The information on your screen with MDFT.org and Gail. Also, feel free to contact me at any time, Dan Rossendi at Connecticut Junior Republic. I'll be happy to talk with you on behalf of MDFT and our services. And we will also post all of the questions that we had going forward. And this is also recorded so that if you would like to share it with your staff or other legislators or other people in the advocacy community, we will make sure that you have access to this and can share this or pieces of it which you would wish to do. So with that, I think we'll close today. If Gail, you have any last words before we go?
Oops, I'm unmuted. No, I don't. I was very inspired by this. Thank you all very much. And as Dan said, any questions, comments, reach out. We're always here. Thank you so much. It's really been an honor to be part of this. Great. And thanks to all our panel presenters and youth and families that shared their stories. And also I want to thank T-Course Capital for hosting this event and doing all the tech assistance behind the scenes to make this happen. Me and Gail would not have been able to pull this off. So I want to thank them all very much. And with that, we will end our presentation. Thank you. Have a great day. Thanks.